All right, guys. Good evening. And this is let's see, what is today? Today is the 10th of April, 2014. This is Midwest Critical Care Collaborative, and I, of course, am Steve Simpson. And we have people on the line from all over Kansas, and from Missouri, and from Nebraska, and from Minnesota. So this really is a Midwestern Critical Care Collaborative. And that's a nice thing. I enjoy that we all have this common interest and we're all here to share it. So what I thought I would do tonight, if it's okay with everyone, I'll go ahead and start talking, but you guys please feel free, by the way, to speak up anytime you want. And in fact, I think maybe I'll turn my camera on so you guys may be able to see me now. Is that true?
Yes.
Yeah, GoToMeeting says it gave me a little message that says people can see you. Okay, that's good. That's kind of cute, actually. I just want to see what you can see, so I get my camera set up, and be sure that you guys are all looking right at me here. And usually I can find that easily enough, but I have so many things open here. You're all seeing my desktop as I close and close and close. And no, actually, I cannot see what the camera is showing. Can you guys all see my face okay?
Yes.
Okay, perfect. Then I will go ahead and start. This is a bit of a funny story. In that last month, I went to the Chest World Congress in Madrid, and I was going over to moderate a scientific session, and that was about my only responsibility. And as you all know, on the Tuesday before that, I sent everyone an email that said the ProCESS trial is out, and then also, as it happened at the same time, there were several other important sepsis um, studies that came out, one including a negative study on the use of albumin in severe sepsis and septic shock, a negative study on the use of a higher mean arterial pressure target in patients in septic shock. And then in JAMA was published right at the same time the results of the ANZICS study, which is a long-term epidemiological study of severe sepsis in Australia and New Zealand. So I was flying from Kansas City to Dallas on my way to the Chest World Congress, and I thought, with all this brand new stuff out, we ought to see if we can have a late breaking session. So I emailed the World Congress organizers, the chair of the meeting, and they said, fantastic idea, we'll do that. So what happened was that instead of having a nice leisurely meeting in Madrid, I gave myself work to do for a couple of days until the presentation got over with. But it was kind of fun because we had um, who was on the panel? Craig Lilly, who wrote the editorial in the New England Journal about the ProCESS trial, was on our expert panel, as was Jesse Hall from the University of Chicago and Jean-Louis Vincent from Erasmus University in Brussels, Belgium, a very famous sepsis researcher. And so we had an expert panel. And what we wound up talking about out of all those four studies was just the ANZICS study and the ProCESS trial. And so I thought I'd just run through some slides here and then we can talk. And I want you guys feel free to interrupt me at any time if what I'm saying isn't coming through, isn't making sense, or if there are just clarifications that you would like. So this is more or less what we talked about, at the Chest World Congress. And the Chest World Congress, of course, was happening the same week that all these studies came out. So this is the ProCESS trial or process trial. I'm not sure how they pronounce it. Randomized trial of protocol-based care for early septic shock. This is the editorial written by Craig Lilly. This is high versus low blood pressure target. This is like the biggest single week in the world of sepsis that I can remember. So So it was kind of a cool deal and kind of a neat thing to be able to have that session and talk to those guys who are some of the smartest guys in critical care. Um, what we wound up settling in on for the duration of that meeting, because we just had an hour to discuss things, was the ProCESS trial and the ANZICS trial. Craig Lilly presented the ProCESS trial, and I presented the ANZICS trial. But so this is kind of what I titled the ANZICS study. Mortality trends in severe sepsis. Why so much fuss when fewer people are dying? And you will see that's kind of an ironic question because it isn't exactly the way. Of course, at any international meeting, you have to declare your disclosures, and these were mine. Um, and so I started with this, the ANZICS trial. Mortality related to severe sepsis and septic shock among critically ill patients in Australia and New Zealand from 2000 to 2012, inclusive, so it was a 13-year study in JAMA. I probably is published in actual print format. Maybe. I haven't seen it come out in the print journal yet, but it is published online at JAMA Online and published on the 18th of March. So what is the ANZICS study and what is ANZICS? ANZICS stands for the Australian and New Zealand Intensive Care Society. It currently involves 171 ICUs in Australia and New Zealand. Um, at the time of the initial study, it was not 171. This is a sort of collaborative, except they are focused more on research than they are on actually um, working together to improve their outcomes. So their focus is a little bit different. This was an observational retrospective study. They have a database. The ANZICS or the Intensive Care Society has a database in which they enter data about all sorts of patients. It began in 1988, I think, with about 6 ICUs, and it has progressed so that through the course of this study, they wound up with 171 total ICUs in Australia and New Zealand. 63 of those ICUs were present for the entire 13-year period. Others were present at various different times. They have in their database data from over 1 million ICU patients, and over 100,000 of those are patients with severe sepsis. They have trained investigators that they use to extract chart data, including that for this particular study, the investigators are trained in reviewing a chart, as many of you are, and finding the presence of severe sepsis there. The study involved patients who were admitted through the emergency department into the ICU with severe sepsis or septic shock. So they specifically did not look at patients on the floor who had developed severe sepsis. So to cut to the chase, these are their findings. What they saw, first off, over the course of that 13-year period is a substantial increase, something like 15% per year, growth in the number of patients admitted to their ICUs throughout that period of time. And that's seen in the blue line up here. The red line indicates the increase in number of cases of severe sepsis per 1,000. And these are rates of admission, so it's all per 1,000 patients. So that we grew from about 1.7 ICU admissions per 1,000 population to above 4 per 1,000 population. Pardon me 1 second. I am going to get my pointer so it quits going away. There. And meanwhile, the incidence of severe sepsis grew progressively during that time as well. The proportion of severe sepsis admissions to the ICU out of all admissions to the ICU also grew during that period of time from 7% at the outset to 11% of all those ICU admissions at the end. So sepsis incidence is going up strikingly in Australia and New Zealand. Meanwhile, what they found was that the mortality from severe sepsis that started at 35% in the year 2000 made it all the way down to 18.4% for the calendar year of 2012. And there was a steady drop, as you see from the symbols here, all the way throughout that 13-year period. So some important features of what they saw. Here, if you look, severe sepsis without shock. Let me see. I'm showing mortality percentages. I thought I had a mortality slide. Oh, I did. I just showed you the mortality slide. I'm getting spaced out here. Sorry about that. So severe sepsis without shock. Mortality fell from 30.2% at the outset to 14%. Severe sepsis with shock, or for short, septic shock, fell from 40% to 22% mortality during that time. As a matter of fact, if you go down this list, if you look on the left, you see all kinds of different ways that they slice the data. Medical admissions, surgical admissions, people with respiratory failure, people with renal failure. Apache scores low, Apache scores high. Age group at the time of the diagnosis. Source of origin of the sepsis. It doesn't matter how they slice the data. Between the year 2000 and the year 2012, there was a substantial and statistically significant drop in the mortality in people with severe sepsis. So there, I just emphasize the point that I had just made about with or without shock. But even though the mortality rate went down, the total deaths went up from 949 in the first year to 2,300. So something's happening so that a lower proportion of people are dying, but more people are dying because the incidence of severe sepsis has gone up so much. Another good byproduct here that they illustrated is, first off, here's the number of deaths going down on this graph over time. These are the number of people discharged to home. And you see that the number of people discharged to home grew rather substantially, while the number going to rehab went up a little bit. Rehab in this case, they say, includes a nursing home that's intended as rehab, and on the purple line, to other places such as LTACs and so forth. So the key finding that they hope to illustrate with this slide is that not only is there a declining mortality, but a lot more people are going home proportionally than had been in the year 2000. So there are several questions that this brought to my mind when I read this study. One is this something that's peculiar to Australia and New Zealand, or is this something that might be seen elsewhere? Two, is this a stage migration phenomenon? And we'll delve into what that means later. Is this related to protocol implementation, such as early goal-directed therapy? And finally, could this be a Hawthorne effect? And does that matter? Yes.
Yeah, Lee Tolman.
Yeah.
Do you think that part of that drop in mortality could be better recognition? And as recognition gets better, you recognize the softer cases, and they get thrown into the denominator?
Well, as it happens, I have some slides specifically addressing that question. So if you don't mind waiting for a couple more minutes, we will get to that. So first question that I asked is this phenomenon peculiar to Australia and New Zealand? And actually, I already knew that it wasn't, because this is a study that I presented in my annual review of severe sepsis at the CHESS meeting last fall. Um, this is put out by Gajewski and colleagues. I believe they're from Pittsburgh, although I don't recall off the top of my head, where they looked at four of the large methods that we have used over the last couple of decades to study the epidemiology of severe sepsis. So the big papers that we all know about, of course, are the Angus paper published in 2001, the Dombrowski and the Martin papers, Martin published in 2003, Dombrowski in 2007, and then the Wang paper, um, which studies only the ER incidence of severe sepsis, number of cases presenting to emergency departments. So it's not quite as widely known for that reason. Um, and I forget when Wang published their study. Nevertheless, so what these authors, Gajewski, did was they got in the National Inpatient Database, which is a sampling, you all may know, it samples about 20% of all the patients in the United States and has data on 20% of the hospital admissions. And they're able to answer a number of questions out of that with that sample. So using the methods that Angus used and that Wang used to identify their septic patients. And you all may remember this just as an example. What Angus used was an ICD-9 code for infection in combination with an ICD-9 code for acute organ dysfunction. And that's how he applied this to the CMS database. So these guys are just applying those methods on an annual basis. They got the annual figures from the National Inpatient Survey and see an increasing incidence in the United States as well. Um, and according to the Angus methodology, we should now, at this point in 2009, if they extrapolate from the 20% to the entire population, what they see is upwards of 2.5 million cases, about 2.7 million cases. The Wang estimate, which is a similar methodology, would have estimated above 3 million. Martin and Dombrowski, who used slightly different methodologies to identify their severe sepsis folks, um, estimated in the neighborhood of 1 million cases. So if you take sort of the mean of all of those, it runs here. And so we think that we've gone from about 1 million cases in 2004 up to close to 2 million cases in 2009. So it's not just in New Zealand where the incidence is going up. Meanwhile, mortality from severe sepsis in the United States was seen to decline as well, starting at 35% in 2004 using the various methodologies, Martin, Dombrowski, and Angus. Wang, of course, was looking at incidence of presentation to the ED, so they don't have mortality statistics. But so we fell from 35% to 25% using these methods. We fell from 17.8% to 12% using the Angus method over that period of time. So very much like what we're seeing in New Zealand, number of cases is going up, mortality rate is going down, but when you look at total numbers of deaths from severe sepsis, the estimates range from 240,000 up to about 370,000, depending on which form of estimate you choose to identify the patients. So again, mortality rate going down, but overall numbers of mortalities going up. Is this a stage migration phenomenon? And this, Lee, is exactly the question you were asking me, which is also known as the Will Rogers effect. So why is it known as the Will Rogers effect? Well, none of us were alive. I don't think any of us were alive when Will Rogers was, but Will Rogers is very famous in Oklahoma, and I was born in Oklahoma. I know a lot about him. He used to drive up and down the Will Rogers Turnpike to go visit cousins and whatnot. Um, and of course, at the World Congress, I had to give people a little bit of a hint of who Will Rogers was. But these, you can see, this is this is a sampling of what the sorts of things that Will Rogers was famous for saying. Like, and I like this one. We're sending congressmen on expensive trips abroad, which might be worth it, except they keep coming back. Well, Will Rogers is known in epidemiology for having said something else. What he said was when the Okies left Oklahoma and moved to California, they raised the average intelligence of both states. So what does that mean? Let me see. Some here. Yeah, so what it means is the Okies were dumb, really dumb, but he estimates that the Californians are even dumber. So if you take away some of the dumbest of the Okies, the ones who can't hang out and stay in Oklahoma, and they move them to California, they're still smarter than the Californians, so they raised the intelligence in California. Meanwhile, you took the dumbest ones who couldn't hack it in Oklahoma and took them out of Oklahoma, so you raised the intelligence in Oklahoma. And this is exactly what Lee was asking me had happened. This is how that might apply if we were seeing the Will Rogers effect related to severe sepsis. So if we would say early on we were seeing people and we were only diagnosing them with infection. But in that group were people who had a simple infection, people who had infection plus SIRS, i.e. sepsis, or people who had infection, SIRS, and organ dysfunction, i.e. severe sepsis. And meanwhile, so let's say most of the world is looking at a lot of these folks with severe sepsis and just diagnosing them as bad pneumonia, really horrible peritonitis, severe pyelonephritis. So they're sitting here in a group called infection. Meanwhile, over here, the experts are looking at severe sepsis and septic shock and making that diagnosis fairly frequently. Now, let's say we train up a lot of people in the world to recognize severe sepsis. So what happens? Severe sepsis now no longer gets this diagnosis of simple infection. It gets a diagnosis that fits with severe sepsis and septic shock. But you would posit that these potentially are the milder cases of severe sepsis. So we've put milder cases of severe sepsis over in this category, and we've taken them out of here. So what happens to the mortality here? It increases. What happens to the mortality here? It increases. So the question is that what happened? Now, let me show you what it looks like. I have to show you some of our data from KU to show you what a Will Rogers phenomenon might look like. So I'll orient you to these slides. So this is us from fiscal year '05 to fiscal year 12. The blue portion of this represents the number of patients diagnosed with severe sepsis in the various years, '05, '06, '07, '08, '09, etc., right on up. The red portion represents, some of you have heard me talk about this before, what we call the modified Angus protocol. Because we want to know how good of a job are we doing at diagnosing severe sepsis at KU. And how can we know that if there's no gold standard? I mean, if it takes recognizing it to know it's there. So what we did was modify Angus's technique just a bit, and we apply that to all of our hospitalized patients that are discharged or die during the course of a year. Um, and, and so we say this is probably the upper bound on the number of septic cases that are in our hospital in any given year. So we look at this and we see we never quite diagnose all of them, but we get better and better, well, fairly better as time goes by. Now, lastly, this is the growth in septic shock cases over the same period of time. And this is interesting. If you look, you can see at our hospital the annual growth rate for severe sepsis, 15.5% year over year for the last, actually, probably for the last decade. Actually, I know for sure for the last decade now because I have a decade's worth of data. Now, so let's replay that a little bit. So if we say that the modified Angus is 100% of all the cases of severe sepsis, and the blue is all the ones that we have diagnosed as severe sepsis, then what happens here? You'll see that in the first year that I'm talking about here, 43% or thereabouts of all the septic cases did we actually diagnose. Over the years, the proportion of all the sepsis that's in the hospital that we are actually diagnosing goes up. Now, should these two lines ever meet? Honestly, I don't know. I honestly cannot tell you that the modified Angus is accurate and clearly does get everyone. I can't tell you that it doesn't overshoot. I can't tell you that it doesn't undershoot. But I think it gives us some sort of a marker to work towards. Now, the thing that the green line represents on this particular graph is the proportion of all the severe sepsis cases that are septic shock during any given year. So you can see that in our first year, fiscal year 05, out of all these cases of severe sepsis, 65% of them, 2/3 of all the cases of severe sepsis in our hospital that were diagnosed were septic shock. Now, so what happened? We began to put our sepsis team into place. We began to train people to recognize and pay attention to it. And so what happens over the ensuing couple of years? The proportion of all sepsis cases that are septic shock drops down to 30%. So we're recognizing better. Meanwhile, what's happening to our overall mortality? It's dropping from 50% down to 30%. Same period of time. This, I believe, probably is the Will Rogers phenomenon because we're diagnosing less severe cases and the mortality rate's going down. Now, for the subsequent 5 years on this graph, I don't think we see the Will Rogers phenomenon because why? Because we're diagnosing a higher proportion of the total number and because the relative proportion of septic shock stays the same. So that's two clues that I think that we had Will Rogers phenomenon quite likely right here in these first couple of years until we got better at diagnosing. And from that time onward, I think it's been hard work that has managed to bring our mortality down, coincidentally to exactly the same mortality as it was in 2012 in the ANZICS study. I find that one fascinating that that's exactly what's happened. But for us, it's been a lot of hard work. For the ANZICS folks, they think that they haven't done anything in particular to make that happen. Let me see. This is why I don't think that it's the Will Rogers effect in the ANZICS study. So if you look at the relative risk for reduction for dying from severe sepsis, you see that you've got a relative risk reduction of 47.5%. If you look at everything else in the ICU over that period of time, you also have a relative risk reduction of 41.6%. In other words, fewer people in general are dying in the ICUs in Australia and New Zealand, regardless of the ICU diagnosis. So that would suggest that it's probably not a Will Rogers phenomenon. Oh, meanwhile, by the way, the proportion of their septic patients who had shock went up from 48% to 54%. So mortality is going down, but the relative sickness of the individuals that they're studying has gone up. So, is it related to a better protocol implementation, like something like early goal-directed therapy? Well, some of us know that the ANZICS authors have been vocal anti-early goal-directed therapy users. And in fact, this is an observational study that they published in 2009, where they looked at patients just over about, what is this, January, that's weird. Oh yeah, I used their term. Okay, I was getting myself screwed up. This is the Australian or European way of writing this. So from September 1st, '06 to January 31st, '06. So about a 5-month period. 32 of their ANZICS ICUs, 324 patients, no evidence whatever in those 32 ICUs of systematic use of CVP or central venous O2 saturation. Overall mortality for that brief time slot was 23%. Um, Time from ED presentation to meeting inclusion criteria, 1.6 hours. Time to antibiotics, 2.2 hours. Um, and IV fluids that they got from presentation to time. So what were they doing? They weren't using CVP and central venous O2 saturation, but they were clearly getting antibiotics in a relatively short order, and preferred fluid bolus was getting in relatively short order. So what about this? Could it be a Hawthorne effect? And what is a Hawthorne effect? We talk about Hawthorne effect all the time. This, by the way, is the Western Electric Hawthorne plant that was located in Hawthorne, Illinois, in what is now Cicero, Illinois. And basically, the experiment was that they brought in outside experimenters to try and improve the workers' productivity. And it just didn't matter what the experimenters changed, the productivity went up. In some experiments, they dimmed the lights, made it so it was harder to see gradually over time. Productivity went up. In some experiments, what are some other things they did? I don't know. I can't just remember, but they would change the conditions the workers were working in, and no matter what they did, the productivity always went up. So their interpretation of what they saw was that the workers' behavior was modified by the presence of the observer. So they became more productive. And this is often how the Hawthorne effect is referred to. In more modern times, around in the 90s and 2000s, people have re-looked at the data and realized that the workers actually got to see their before and after results. And so what they are thinking is that the workers responded to measurement and feedback, getting more productive because they saw their measurement and got the feedback and actually made changes. Well, I find this one fascinating because this, of course, is the whole reason that, yeah, I'm going to stop sharing my webcam. It just asked me because it says our connection is a little slow. So the more modern interpretation is just right in line with the principles of quality improvement, which I find fascinating. So they had an accidental quality improvement process because the workers could see and respond to their own results. This, by the way, just for fun, you may recognize this is the Hawthorne plant again, and this is all that's left of it. Sits behind a strip mall in Cicero, Illinois, and that's what it looks like today. So the Hawthorne effect, could this be a Hawthorne effect? Um, it is entirely possible that because they are looking and because they are seeing their feedback, this is the descriptive study of the ANZICS database, and what they said was from the get-go, our whole point is to show each other, show ourselves what we are doing. And therefore, they are, yes, participating in sort of a Hawthorne type experiment because they have feedback on how they're doing all the way along. And of course, as we know, that when you do give feedback, here are just a couple of the studies that have been published. One in Spain, I had to show this one because I was in Madrid. Um, they didn't get as good a results as the one in Salt Lake City, or I should say the Intermountain region, where they clearly showed that if you implement a severe sepsis bundle and if you give feedback and if you track your processes and results, you clearly can reduce your mortality from severe sepsis. So for that particular segment, what I concluded was that the mortality rate for severe sepsis and septic shock probably is declining. We know for sure it's declining in Australia and New Zealand. We know for sure that it's declining in the United States. It probably is not magic, probably involves focused effort on early recognition and rapid aggressive responsiveness, but I can't prove that. However, I do want to go back. It was actually in the ANZICS study. Yeah, this proportion here, this half was to show that they were not using SCVO2 and CVP. These data are from the ANZICS trial as a whole from 2000 to 2012, literally showing that what's happening is they're diagnosing severe sepsis within 1.6 hours of presentation at the ED. That's the median time. The median time to get antibiotics, 2.2 hours from presentation at the ED. And the median or the mean amount of fluid and standard deviation of amount of fluid that they are giving in the ANZICS study is over a liter and up to 2 liters of fluid over the course of the first 1.6 hours. So what are they doing? They're giving early fluid boluses and they're giving early antibiotics. So the reason I presented ANZICS first is because it shows a reduction down to around 18% in the baseline mortality for severe sepsis. Um, and that's important because one of the criticisms of the ProCESS trial is, hey, your mortality rates are so low, this clearly isn't the same people that we've been talking about. So this paper also was published on March 18th, 2014, only published in the New England Journal. And again, protocol-based care for early septic shock or ProCESS trial. So what was the ProCESS trial? It was a randomized controlled trial intended to test whether we actually need to do all the components of early goal-directed therapy or not. So there were 3 groups in this trial: early goal-directed therapy, protocolized standard therapy, and usual care. So what does that mean? Well, we all know what early goal-directed therapy means. We've all been aiming to do that. The protocolized standard therapy allowed central line placement, but only for delivery of fluids or vasopressors. Of course, there were written protocols for how the study sites were to do these 2 things, and they're in the paper and are substantially similar to the Rivers paper on this, and with a substantially similar process of doing it for protocolized standard therapy. The usual care was left up to the care teams. Of course, care teams were trained. This is where you will see that I think Hawthorne effect does play a role here in this study as well, because it's the same investigators or the same treatment teams carrying out this, and this. And it seems impossible to imagine that some of the principles from this and this did not bleed over to usual care. The protocol specified the amount and timing of fluid, but not the type of fluids. The protocol specified thresholds for vasopressor use, but not the type of vasopressor to be used, and all other aspects of the care were determined by the physician leading the team. Primary outcome they were interested in was 60-day all-cause mortality. Secondary outcomes were 90-day mortality rate 90-day and 1-year cumulative mortality, ICU length of stay, hospital length of stay, duration of shock, acute respiratory failure, and acute renal failure, hospital discharge disposition, and serious adverse events. So these are the characteristics of the patients at baseline. There functionally are no differences among the groups um, in numbers or proportion. The study wound up with somewhat over 400, between 440 and 450 patients per group. Um, as you can imagine, pneumonia was infection, as it is in every one of these studies, followed by UTI, as it is in every one of these studies, followed by the various other infections that can be there. Apache scores were similar. Entry criteria were similar. Um, nearly nearly everything about the baseline was similar, with one exception that we will get to right shortly. I will show you in just a moment, but this slide actually shows outcomes. So outcomes in the early goal-directed therapy group, 21% mortality, standard therapy protocol-based, 18%, usual care, 18.9%. So, and there was no statistical difference among these groups. Same at 90 days. Um, organ dysfunctions, all the same, close to statistically significant here, with the usual care being slightly better, but not quite statistically significant. About the only thing that was statistically different among these groups is, let me see, is this the one that has central line insertion? That may be on one of the coming up slides. Central line insertion was 97% in the early goal-directed therapy group and was only about 55% in the other two groups. Admission to intensive care unit, as you can imagine, was a little higher in the early goal-directed therapy group, as it should be if you're inserting central lines and giving pressors and monitoring CVPs, etc. This is the Kaplan-Meier curve of 60-day mortality. You can see those curves are functionally no different. This is the cumulative mortality to 1 year. You can see those curves are no different. So, the big question that's going to arise is, it doesn't seem like our protocols made any difference here. So does that mean we should throw away our protocols, and does that mean that everything we've been talking about in the last couple of years about aggressive treatment of sepsis is incorrect or wrong? Well, um, obviously, I wouldn't have posed the question that quite that way if I thought that we should get rid of protocols. However, there are some things. Oh, this is the slide, by the way, that shows central venous catheterization higher um, and higher use of the oximetric catheter. Amount types and amounts of fluids, I think, are better addressed on a slide that's coming up. So, do we need to abandon our protocols? Not, not quite. And the reason for that is, now I didn't have time to expand this out the way that I did the other, but I want you to look at a very, very important thing. I think I left off the slide that shows how quickly these people were identified, but these people again were identified in about an hour and a half from the presentation to the emergency department. And look at this line right here, intravenous antibiotics. This is how many, before they got randomized into groups, what proportion had intravenous antibiotics. 75%, 77%, 76%. How many people, well, and then let's take a quick look at before they got randomized, they had received over 2 liters of fluid in every group. So in essence, what we're saying is that we've been saying for a long time that the absolute most important feature of all of the sepsis bundles is early administration of antibiotics, followed closely by early aggressive administration of fluid boluses. And guess what? They did that to every patient in this study before they even got randomized to the type of treatment. So they gave the key treatment for severe sepsis before they separated them into groups. And quite frankly, that explains in my mind why we found no difference among the groups. If you look down here, intravenous antibiotics in the first 6 hours after randomization, we're up to within 6 hours nearly every patient in the study, and no differences among them, has had antibiotics. If you think back to the Kumar study, you remember the study of antibiotics and septic shock, you will remember that 6 hours was the median time to receipt of antibiotics in the Kumar study, and also associated with rather large mortalities. So my take on the ProCESS trial, bottom line, is it's very much as we've known for quite some time, that you have to recognize early and quickly, which was done in all three groups, that you have to give antibiotics quickly, which was done in all three groups, that you have to give fluid boluses quickly, which was done in all three groups. Now, so here's the big question. What people are going to do with this ProCESS trial, and you know it and I know it, is they're going to say, hey, there's no difference with protocols. Why should we pay any attention to protocols? And the answer is that the protocols were done after the fact, and where we need the protocols is here. I have yet to go to any hospital, my own included, and see that as many as 20% of people at the baseline are getting antibiotics within an hour, within 3 hours even. Most people just aren't getting their antibiotics that fast. If you look at what I would call the wild type, standard therapy in this study is not the wild type. Standard therapy in this study is people giving treatment with the Hawthorne investigators looking over their shoulder. And that is an altogether different animal. And that's what I have to say about that, to quote Forrest Gump. So, I don't know if you guys got a chance to read these studies or what you think about these studies, but I'm interested in hearing your thoughts now that I've chewed up most of an hour.
Steve?
Yes.
Lee Tolman again.
Yeah.
In the ProCESS trial, I think it was around 2011, they changed their definition of septic shock and allowed people with, I think, under 20 cc's per kilo. They allowed people that just had 1 liter and then dropped their blood pressure into the study. So they diluted it with some less sick severe sepsis cases.
Yeah. Yeah.
And that kind of, I wonder if this isn't, this ProCESS trial isn't more true for the less sick, and we still don't know about that subgroup of septic shock that has 4 organs down or more.
Right.
And whether that CVP monitoring and SCVO2 is more important in that group.
Right. And I would agree with that. And they even mention in their paper, too, that, well, as one mechanism or means of comparison. So the River study in 2001, the average lactate of the admitted patient to that study was 7, whereas the average lactate here was 5. So I think what they're saying is kind of what you're saying, only not as blatantly. The other thing that I think this does, though, for us is we have needed for a long time a study that compares that compares other means of administering volume or measuring the administration of volume to patients with shock in general, and septic shock in particular. And I think this opens up the pipeline so that we already at KU are cranking up a study to use stroke volume as a target, because we think that CVP was the wrong target all along. It doesn't help you
Mhm.
with the patients that you are talking about, and you need a better fluid target there. So yeah, I'm right in line with what you're saying, and I agree with you.
That was a beautiful presentation. It was just eloquently um, portrayed what I've been trying to think about for a long time.
Yeah, well, good. Thank you. I appreciate that. And we had a nice time. We have a nice big art, discussion between Jean-Louis. I don't know if you guys have ever seen Jean-Louis Vincent, but he's a very flamboyant Belgian guy, and he doesn't state any opinions mildly. Yeah. Um, So yeah, my bottom line on this is we absolutely have to continue our programs for early recognition and early antibiotics and early fluid administration. And we have to reopen the question of how should we deliver those fluid boluses, and how should we know when we've given enough fluids. Um, so we're doing that at KU. We have started writing a protocol so that we will compare stroke volume targeted resuscitation with CVP targeted resuscitation, which is going to be kind of hard for us because we don't really believe in CVPs anyway. But we've been doing it because it is the surviving sepsis um, recommendation. Next month, by the way, I will be able to tell you, because we have scheduled a special session for all of the participants in our Surviving Sepsis campaign collaboratives to address how shall we proceed given these results. And I'll hear what Mitchell Levy and Phil Dellinger have to say on that topic when we do that.
Steve,
Yes.
this is Gary Carter from North Kansas City Hospital.
Yeah.
I'd like to ask one quick question.
Sure.
What do I say to our anesthesiologists who have read the New England Journal article and are pushing back on central lines? Not necessarily all central lines, but the precept lines, they say, are too big, too stiff, too rigid, too prone to iatrogenic injury.
Mm-hmm. Well, I'll try and frame my approach to this. Last year, Gary, before you guys had joined our collaborative, we sent, as the Midwest Critical Care Collaborative, we endorsed a letter from the ACCP to the National Quality Forum that said, it's functionally, it said the ProCESS trial and the two others that are very similar to it, the ARISE trial, which is actually being performed by the ANZICS investigators, and the PROMISE trial, which is doing the same thing but in Europe, um, that we think before you give your National Quality Forum recommendations, you should wait for the results of all three of these trials. And so as soon as ProCESS came out, some of the people at the ACCP sent out a thing and said, okay, should we send another letter to the National Quality Forum based on this? And I said, if we send a National Quality Forum letter right now, it's going to look like we have an axe to grind, because what we told them last year was wait till all the data's out before you make a change. So that's a long-winded way of saying that I think this is one study. I know of two others. The other two studies are going to be, we think, even larger than this one. And I think it behooves us, before we change our approach, to see the results of those two other studies. Um, I think that's the best data that we have. I have a lot of thoughts that are just based on experience, which is a little harder, which is that yes, if your central venous O2 sat is low, and if you can fix blood pressure and bolus fluids adequately and get it up, people quite clearly do better. And that's our 10 years worth of experience doing that. And that's why I'm not convinced that we need to toss that out. As a matter of fact, in this ProCESS trial, I forgot to say this, that the average SCVO2 when they put in the catheter was 70% in all the groups.
Okay.
Let me, oops, I'm in the wrong place. Let me, phooey. I was trying to back up here and get to that slide. The problem is, as Manny Rivers will tell you, you don't know what it's going to be until you get in there. Oh, maybe it's not on one of these tables. I thought it was.
How could they have it if they didn't have a central line? They must have all had central lines.
Well, in the early goal-directed therapy group, they all did, remember? So what they
Yeah.
were saying is in this group, when they put it in, the
Oh,
average central venous O2 sat was already normal. So,
okay.
in point of fact, that's your argument. You go, well, if it's already normal, you can't normalize it with your treatment. So you couldn't possibly expect to see a positive result from doing that, right? And so that's one of the flaws of the study. The people, quite simply, were not as sick as the people in the River study to begin with. So anesthesia is pushing back, but I think my stance Well, my stance is this, Gary, is that I think that if people choose stroke volume monitoring and lactate clearance as a choice, I don't think anyone can throw darts at them right now. Um,
Okay.
I really don't think you can. But you have to, what's happening is, and I can tell you this, I'll bet you anesthesia is pushing back on that. They just don't like putting those catheters in. And they're not saying, instead, let us put in an art line so you can have a flow track monitor and you should do repeated lactates. They're just not wanting to put the lines in. You know what I'm saying?
Yeah, we have a follow-up meeting next week, and we've invited them to attend it. So it'll be an interesting discussion. I'm not trying to portray them as being antagonistic. It seems like it's just this precept catheter that they have a problem with, just
Okay.
that device itself. So
Well,
I think they're willing to do it.
but yeah, okay. Well, and you know what we have fallen away from the precept catheter at KU. Um, wouldn't shock me if I really delved into it to find out that that's why, just because people don't like putting them in as much. Um, However, Paula Ising, who's on the line, actually um, presented and won an award for her presentation at the chest meeting several years ago that using the Precept catheter in their hospital actually resulted in better bundle compliance, i.e., in better, um, actually, all the way across the board, but you got to the
and
design
lower mortality.
and lower mortality, and you got to the 70% that you're shooting for faster, more consistently in a higher proportion of patients, and fewer died. Thank you, Paula. I should have just let you say. Sorry.
But that's all right.
Hmm.
They also took out almost all the patients we have, like no-code patients and patients that are transferred to you from another facility.
Right, they did do a lot of that.
And,
Exactly.
and our mortality is lower, so I think we're sticking with what we're doing.
Yeah. Well, and I think that there's a reasonable argument for doing that, and you've seen your mortality go down and stay down, and so I don't think you change when things are working. And so Gary, I haven't. You know how I hack around in the database and see how people are doing lately. I haven't looked lately to see what your data is looking like. Do you know if your mortality's changing at all yet? Or,
North
or
Camp, we started our big push just about a little over a week ago, so
gotcha. Okay.
we're in the rollout phase.
Yeah, still in the rollout. So too soon to tell. Cool.
Nice presentation, thank you.
Yeah, you're welcome. Thank you. Anybody else got anything? Questions? Comments? It is 7:01, so I won't take away any more of anyone's time unless people do have something to say.
Steve, can you go back to that slide on the Will Rogers
Yes.
effect group? Just
Let me see. I'm going the wrong direction. One second. Okay.
and the one after that.
The one after that. Yeah.
Yeah. I thought I heard you say that when you moved that severe sepsis from the infection side to the severe sepsis side, that the mortality went up in both sides, but actually I think you meant that it went down.
Oh yeah, it went down.
Sides.
Sir, survival went up and mortality goes down. I hope I didn't because I recorded this for posterity, so I hope I said it right. Cool. But yes, exactly. Mortality goes down in both groups by doing that if there's a Will Rogers effect. And I think early on you do see the Will Rogers effect based on what I showed you here. But then it levels off and then it's just hard work getting things done better.
Whose metaphor is that? Is that yours?
What's that?
The Will Rogers effect.
Oh no, it's not mine. That's been an epidemiologic thing since for a long time. Yeah.
Okay, I didn't know that one.
Yeah. Yeah, they used to say it a lot about where I first heard it was in lung cancer staging. You know, if you start sampling more nodes in the chest and you find some microscopic metastases, that now becomes a stage 3 or a stage 4 cancer when you used to call it a stage 1 because you just had a small nodule, right? And so you take those out of the stage 1 and stage 1s get better and you put them into the stage 4s and these are the nicest of the stage 4s, so they get better too. So that's where I first heard of it. All right, guys, it is over past 7 o'clock, and you guys are real stalwarts for being here until 7 o'clock in the evening. And I enjoyed it, and we will talk some more next month. And what did I say? Oh, and next month I'll let you know what Phil Dellinger and Mitchell Levy say about what we're going to do on our Surviving Sepsis campaign collaboratives about this data. I know Mitchell. I know that Mitchell doesn't think we should change anything yet, but I'll hear what he has to say exactly, and then we'll chat about it.
Okay.
Cool.
All right, thanks a lot, Steve.
Yeah, thank you, guys. We will talk to you next month.
Okay. Bye-bye.
Okay. Bye-bye.